Joanne.
Good morning, Candida.
We're just talking about how glad we are to be inside doing this morning because it is beastly hot out there.
Yes. My grandmother used to say if it was probably less hot than this, being in Maine, but if it was this hot, hotter than the hinges of hell. I always found that to be a fun expression.
I like that so much, rather than not just hotter than hell, which we use all the time, but hotter than the hinges of hell, which is like metal in hell. It's perfect. Right. It's
not sure what the hinges of hell actually are, but I always found that a fun and useful expression.
Well, it feels like that today, so here we are, staying cool in my basement. You in your basement too. We're down.
Yes, exactly.
All right. So what are we talking about today?
So today we are talking about, there's been in the news over the last little bit, a couple of things about some medications that people might be using related to mental health. And those are SSRIs, selective serotonin reuptake inhibitors, which I just recently learned how they work, and which we'll talk about, and ketamine. Both have been in the news. We thought it might be good to just do some Q&A, kind of let people know some of the ins and outs, not necessarily pros and cons, but ins and outs, kind of what they are.
Information. And just a reminder, this is never medical advice. This is just general conversation. And it's not education advice either, but it's very relevant to be talking about these things because, we're thinking about kids, adolescents, and with mental health needs, or just broadly the mental health of adolescents in school. And many of the students you work with and many younger people now are prescribed something like an SSRI for their anxiety or depression or OCD. And so I think it's really important and valuable for us to be thinking about that broadly.
Sure. And obviously if you have concerns or questions, you would talk to your own prescriber.
Exactly.
But so let's just start with SSRIs. What are they and why would somebody be prescribed?
Why are they prescribed? So SSRIs are, as you said, selective serotonin reuptake inhibitors. And the central mechanism, as we understand it, is, and we don't have a whiteboard here, but we are doing video now, so we can, so they work in the synapses between cells. So just as a, reminder, there's two brain cells, they communicate with each other over this space called the synapse. And transmitters go from one cell, and then they're picked up on the receptor on the second cell. And that is part of this neurochemical, electrical system of communication that sends messages through the brain, through the central nervous system to tell it what to do. It's all this communication. So the selective serotonin reuptake inhibitors, if serotonin is moving from one brain cell to the next, once it's done its job on the receptor on the other side, it gets vacuumed back up into the first cell by it's called a transporter, the serotonin transporter, sucks it back up. And then it's in the first cell, and it's ready to come back out and do its thing in the synapse. These medications block the vacuum cleaning. They, not entirely, but they make it harder and fewer of the serotonin cells to get sucked back into that first cell. So functionally, then you have more serotonin in that synapse and more serotonin available to hit the receptors on the other side. And so that's one of the mechanisms. They do other things, and within the group of them, there are some differences in some of the other receptors that they hit or how they actually work at the transporter site. But broadly speaking, that's what happens. And they are used to treat depression, anxiety, OCD. Those are sort of primary, but they do have other uses for other things. But those are our primary reasons that we use them for. Fluoxetine, which is sort of the old granddaddy, Prozac, the generic name is fluoxetine. That was released on the market right when I was a resident and a trainee. And it was the first one in this category. And since then, there have just been many, many more. And they're effective and safe in big numbers. They do what they're supposed to do. They are not for everyone. Some people can't tolerate them. Some people they don't work for. So like any medication for any kind of disorder, they're not, one for all and all for one. But that's how it works. At least again, that's the sort of main mechanism that we know about. And those are the diagnoses that we will most often use it for. And because many of those overlap, depression, anxiety are often overlap, not always. And OCD, bit thrown in there, obsessive compulsive disorder. Of course, it can be nice because it will treat both.
So I know one of the things about this type of medication is that it doesn't work instantly.
That's right. That's right. That's a very important thing that prescribers will always talk about, that this is not something that's going to treat your anxiety or your depression the next day. They take several weeks, even up to a couple of months to have their full benefit. Some take longer than others, just because of how they are broken down in the body and how long they exist in the bloodstream. But it can take a few weeks. That doesn't mean it always does. I would say that I certainly have some folks who within a couple of weeks begin to notice some bit of improvement. So it's not that you're always going to have to wait 12 weeks, but that tells us having that ballpark gives us room to say, well, if we're not quite seeing what we want, sometimes we just have to have patience and wait, which can be really hard when you don't feel well, right? It's like, doc, like I don't feel well. I got to wait another 8 weeks to get better. And it's sometimes yes, but again, that's an individualized conversation with your doctor. But patience is part of it. There's 2 levels to the time frame that it takes to get benefit. One is we don't start at a full dose with most of these medicines. So you have to start at a lower dose and work your way up. So that's already going to take some extra time. And then even when you're at the effective dose, it's going to take some time for the medicine to have its effect. So there's like 2 layers to why it takes longer. But that's, especially when you're first using these medications, that's why you should be having regular, frequent meetings especially for young people, with your prescriber. Have a way to communicate with them between visits, if there are concerns. But that was a long answer to that short question, which is it does take time.
And I know sometimes with some medications, when somebody starts taking them, they have some initial side effects that might go away,
right.
But can be discouraging. So what might be some of those sorts of side effects?
So the most sort of potentially common early, usually transient or temporary side effects, things like nausea, diarrhea, headache, sometimes tiredness, alternatively, or at the same time, some lightening of sleep, meaning, maybe some trouble falling asleep, but just as often feeling like you're not quite falling into the same deep sleep as usual, like you wake up a little easier. All of those are usually quite transient. They will pass within a few weeks or even less. And of course, starting low and going slow helps reduce some of that effect. So those can be discouraging, certainly, and not feel well, and something that we always want to be keeping track of. I'm just going to go ahead and jump into the things that can be, more worrisome that we need to pay attention to, especially in the beginning, that there can be, and this is more relevant in young people, like the younger you are, up until about age between 25 and 30, the risk of a paradoxical reaction, sort of feeling worse, more depressed, more anxious, agitated, irritated, activated, just not feeling well on it. And we do see this can happen. And truly, it's hard to tell the exact percentage. I would say maybe 10 to 15% of the time. So it's a chunk of people. And again, particularly with young people, why you are monitoring, starting low, going slow, and monitoring and communicating at the beginning. Some of this, a little bit of that is sometimes transient and okay, like if it's bearable, but anything that looks big and lousy, like, ugh, that means we stop the trial right away. So that is one thing. There is, in any age, there is if someone has bipolar disorder and we don't know it, perhaps in a young person, one thing we do have concerns about are the possibility of triggering a manic episode. Again, this is rare. It's not that common. I wouldn't say rare, but it's not a common disorder in kids. But if they have or are going to eventually have bipolar disorder, sometimes we might see them lean toward a more manic-y, hyperactive, not sleeping, not needing to sleep, not insomnia, but like wired for sound, total, really that kind of thing. So that's something we have to keep an eye on, and prescribers have to be cautious. They have to know about family history of bipolar. And lastly, I'll talk about two things that get a lot of headline. One is suicidal ideation as a potential side effect. There is a small, statistically significant, but clinically not especially significant risk of developing suicidal thoughts when you're first on these medications. And that, again, is more, the younger you are, the bigger the risk. You get to young adulthood and as it starts to fade by around 25 to 30. It is a very tiny number of people. The amount of risk is tiny. The amount of risk to start is tiny. So the increased risk is tiny, but it's, severe. And so we always talk about it. And again, key to managing that is communication, knowing about it, being clear about it, and managing it. Having previous suicidal thoughts does not increase your risk of developing suicidal thoughts. So it's interesting. So that's something we have to pay attention to, but in actuality, clinically remains very, very, very low risk. There's an even lower risk in a very small number of people of some increase in this sort of activation that can be associated with acting out behavior as opposed to suicidal thinking or aggression. But this is also a very, very small percentage of people. The vast majority of people that take these medications will never, ever become aggressive. And I just want to be clear about that because that is a common misconception. It's also a common misconception that suicidal ideation is, like everybody who takes it is going to become suicidal. These are much more likely to reduce suicidal thinking and help someone feel better. And they are much actually more likely to help reduce reactivity and dysregulation that may be associated sometimes with aggression. So those small risks are small compared to potential benefits.
But so as you say, communication with your prescriber, caregivers, if you're a parent with a young person or the
right.
person themselves, be sure you let people know if these are the things you're feeling.
Yes.
And then that brings another thing
school should know. School should know too.
School, exactly. Yes. Yeah, we often get just a little note from the school nurse saying so-and-so. They don't tell us what the medication is, right, but just that somebody has started a new medication. Right. Let us know if you see. And sometimes it's just see changes, and sometimes it's, are they falling asleep or whatever. But anyway, one of the things I did want to bring up is there was a conversation in the news a little bit ago about people should stop taking SSRIs because I don't know why. It just was like, you don't need to be doing that. You could stop. That seems counterintuitive to me. And based on what you just said,
it's counter science. It's counter decades of medical and scientific experience. The stigma against mental health and mental health medication has been around forever, ever since using medication for mental health needs. There's always been a school of thought that's like, no, you can just tough this out. That's simply not true. And anyone like myself or anyone who prescribes or supports families and has sat with people in such pain and such despair, and to see when they feel relief and the way it changes their lives. Again, not that it's all easy or that it always works that way, but to see the amount of struggle people are in, that it's not, you can't just nutrition your way out of this, exercise your way out of this, yoga your way out of this, sit outside enough, sound bath enough. Like it's not, this is not, these are, concerns, challenges in the central nervous system that deeply affect emotional and behavioral symptoms. Those are symptoms in these cases. It can be hard because there's a spectrum, right, into the normal sort of mood changes of sadness or anxious. But we're talking about, for medication, people who are suffering in a way and struggling in a way that is not responsive to these other kinds of more typical supports, or they don't sort of come and go. They stay, they come and they stay, and they disrupt lives. So the idea that SSRIs, or we'll just stick with them, are, sort of somehow this horrible thing that nobody should take and that you should tough it out. And if you take them, I hear this so often, that you're giving up. You failed. You haven't tried hard enough. You're weak if you decide to take medication. And that is, we spend a lot of time trying to help people understand that it's just a tool. It's one of the tools in the toolbox, just like other tools, and other medical interventions. I compare it to asthma a lot, because asthma can be managed with lifestyle depending on the severity of it. Some people with asthma, if they control their allergens or whatever, they don't always need meds. Some people have such bad asthma, they need meds all the time, no matter what, right? Or you can anyway, and everything in between. So it's very, very similar. And just the second half of that question, which is just, you shouldn't be on them, is then just stopping them out of nowhere is not a good plan. Like, oh, I shouldn't be on this, I should just stop it. Please talk to your prescriber. Please talk to the people who are helping you with this. Do not stop your medications all at once. The SSRIs, for the most part, and there are sort of differing schools of thought on this, and there can be withdrawal, and some have more so than less. But it is not a medication you want to just stop all at once. And if it is your goal to decrease it, hopefully your prescriber will be open to listening and having that conversation with you. If you're not tolerating it, or you just have questions about being on it, of course, but I strongly just encourage people to make sure you continue it as a conversation, and not just sort of impulsively say, oh, never mind, I don't want to do this anymore, and just stop it.
Good point. So I think this would be a good point to go to our second topic. Ketamine.
Right.
In the news, different times for different reasons. I'm sure a lot of people are curious about it. I certainly have been. And I did do a little looking up as a person not knowing too much about it. And of course, it was originally approved as a general anesthetic, right, for like short surgical procedures.
And it's still used to this day.
Very effective for that, and for pain management in certain cases. But somehow, and I'm not sure how this came up, it was discovered that it could, in certain instances, help with otherwise resistant treatment for depression.
Right.
So that's kind of what we wanted to talk about a little bit today.
Good summary.
And I would also say, also known as a recreational drug, which of course we would never recommend. And I'm sure there's just a ton of risks around using it recreationally, 100%. Without medical supervision.
Yeah, 100%. Cannot emphasize that enough. It is not to be used without careful control. And just to sort of top of the conversation is there are no approvals at any level for people under 18 for ketamine. So if you have maybe an older adolescent that, it's a consideration, that would be something that you would do in a clinic, research center, that kind of thing, but it's actually not approved. And here's the thing, it's not approved at all for anybody by the FDA. There are no FDA approvals for ketamine. Now, we use medications off label all the time. So that's how you're seeing it being prescribed all over the place. But in terms of as a psychiatric medication and, where it fits into our story, it is for, as you said, treatment-resistant depression that has not responded in adults or, older teens, young adults, perhaps. And the only research that, the only thing that has been fully shown in research, and it's great data, is intravenous infusions of ketamine that lead to rapid antidepressant response. And that's the thing that is so different than like the SSRIs we're talking about, any of the medications, like rapid. And that is very different. It's not everyone, and nobody really knows how long it lasts and whether you need boosters. And for now, that's usually what it is. People get 2 or 3 sessions per week and continue with boosters if they get a good effect. But that format is in a clinical setting, research setting, intravenous infusions. There is a nasal spray called S-ketamine that was approved by the FDA and has some use. It still has to be given in a specialized center. I don't prescribe it because you need to have a place where you have a nurse and can monitor blood pressure and that kind of thing for a couple hours after. So that is specialized support, and some people want to try that before trying ketamine. Now, side effect wise, potentially dissociation, I think, is the thing that's the appeal to it, sort of recreationally, the sort of dissociative, and in higher doses, even sort of, like hallucinogen type effects. But it can have terrible side effects. It can create, really nervous system changes, vascular changes, hyperthermia, fever, collapse, of your whole sort of cardiovascular system, psychosis. Now, in the low doses that are used, it's more manageable. Blood pressure is monitored, temperature is monitored, and some dissociation, but not usually psychosis as a side effect. But those are the things we worry about, and especially because now it is being prescribed off-label in centers all over the place who have just said, "Oh, this is a good idea. Let's do it." And it's also it's being prescribed orally, not just intravenously. Like there's lozenges, like you can get it in any form now. And it's really kind of out of control in my mind because the data is simply not there to sort of long-term data or how will you have to be supervised. The degree of supervision and care being taken in some of these centers is very inconsistent. So if I have a patient who has treatment-resistant depression, we've tried many things, and I really want to try to consider ketamine in an adult, we will make a referral to one of the university centers. I have a couple of people who have gone to reputable, affiliated off-campus centers for IV infusion. That's kind of it's very much in process. It's fascinating because it's rapid relief when it works. It works in a different system than our serotonergic agents or other agents that we have. It works in the glutamate system, which is, so there's a lot new and interesting. And I think there's a lot that's going to be happening with it. But I just want to encourage people to be very cautious and skeptical even about wild claims, too good to be true claims, as if there's no potential side effects. Speak to your doctor, speak to your prescriber. Only take this on if it is something that you have come together and thought about very carefully, and the place you're going is a respected and well-designed place, I guess.
And it sounds like, and I've, know a couple of people who've tried it as well. It is a time commitment because you do have to, depends on where you live. You might have to travel a little bit to get to a place, and then you have to stay there for a little bit to, like you say, to be monitored, make sure the side effects aren't going to be harmful, and since we don't know, it's like how long is the right amount, how many doses are the right amount, we don't know that does add some question into it. So we just thought it would be good for people to have a little intro to what some of the factors are around this. There's certainly a ton of information out there, and we cannot certainly say anything about the reliability of information, but for any medication, you want to do your own research, certainly talk to qualified prescribers, MD, whoever you work with, and just be mindful.
100%. And I think in terms of sort of connecting this back to our teens and our adolescents and, who are suffering with something like a depression, they've tried a bunch of medications, and they may hear about things like ketamine. Of course, kids hear about all kinds of things.
Right.
And whether or not kids who are impulsive may decide to try to, find their own, or, families who are really sort of desperately trying to support and take care of their child who is suffering. So it's, we want to make sure that we're just trying to get all the information out there. We want teachers to be aware of this, people in the building, educators broadly, to sort of have this sense of this is out there. And it's something that people are talking about, and just to have some of the facts and some ideas. We'll of course post any references that we use today, places you can get more information, reputable places to get more information. So, yeah. So, and lots. We can do this again. We got other topics to think about. Actually, I'm going to tease something now. We can talk about TMS at some point, because that is being used in adolescents, not as often, but transcranial magnetic stimulation. It is the other of treatment-resistant depression intervention that is getting a lot of increased use. There's a lot more research on it than there is even on ketamine, and I've had a number of folks receive it. So we'll save that for another time, just a little tease if somebody wants to hear about that. We have a good thing today, Joe?
Well, I would say it's air conditioning.
I would agree.
By the time this episode gets out, hopefully it will still be summer, maybe, but this first heat wave on the East Coast it's only the second day. Hopefully it won't last too long, but but this early in the summer, it's quite
so thank goodness for air conditioning. And also, just as a little, keep in mind that many psychiatric meds can make you more vulnerable to overheating. The SSRIs a little bit, but another family called the SNRIs, close related. Anyway, be sure again to check with your doctor, because vulnerability to heat and actually to sun impact any medication you're on, you should make sure you understand. But antidepressants can make you more vulnerable to heat. That's not a good thing, but that is a thing that just came to my mind. Air conditioning. I have lots of hydration. I have all these different little, flavored packets for my water, just because it makes me drink more water. So that's what I do. And just trying to hydrate and get through the next few days, and hope everyone else is safe and doing the same. So, all right. So we'll see everyone on the other side. If you like what you hear, please hit that like button and follow button, and tell people you know.
Write us a little review. It could just be, I like it. I don't know. You don't have to
a good review. It could be an emoji, just a smiley face, just some interact with us. Our website, mentalhealthgoes2school.com, is another place to sort of find us and interact with us. If you have an idea for a topic, or you have questions for us, or ideas for people for us to interview, we really want to hear from you. So, Joe, we will see everybody on the other side.
All right.